Thank you very much, Dr. Ma, for your kind introduction, and thank you, the organizer, for inviting me to give this talk, which I think most doctors will encounter sometimes in their daily practice. I shall try to set the scene for the coming session with some of the interesting cases which I encounter over the years and introduce a streamlined and integrated approach that may help to speed up the diagnosis and avoid a shotgun approach to the problem. The first case is a 24-year-old male who presented with 5 days of fever. He has traveled to Thailand and had hiking there. On physical examination, there was a maculopapular rash over his body with some non-tender lymphadenopathy over the cervical and the groin region. The white cell count was 4.9, platelet was 130, and there was a blackish eschar on examination of his groin. And the first Rickettsia antibody was negative, and his fever responded within 1 day of starting doxycycline. Here is another case of a confirmed strep typhus with the rash on the limbs and a very inconspicuous eschar over the left ankle. In both cases, the second Rickettsia theta come back to be very high. So these are a confirmed strep typhus case. The second case is a 53-year-old American banker who had no history of recent travel, and he complained of fever and chills and malaise for 10 days for on and off before admission. There was no other systemic symptoms, and the white cell count was 8, with some mild atypical lymphocytosis, and liver enzyme was mildly raised, and the ultrasound showed a 15 cm splenomegaly. Here is the chest X-ray on admission, which was reported as no definite consolidation. But when I compare his chest X-ray performed for routine health check 2 months ago, trust me, there was some new changes over the right lower zone in this present chest X-ray. And he was treated with a course of ceftriaxone and doxycycline empirically with the working diagnosis of CAP, especially atypical pneumonia in mind. It took him in like 7 days for the fever to respond, and his Mycoplasma IgM came back to be positive. Then there was a serial rise in IgG. Extrapulmonary manifestation may precede or happen after Mycoplasma infection. Mycoplasma infection accounts for up to 1/4 of PUO cases in children, but this differential is usually not considered in adults. They do not respond to beta-lactam group like penicillin or cephalosporin group of drugs, and there's emerging macrolide resistance in this part of the world, and tetracycline should be considered in someone without contraindications for these infections in this part of the world. And the third case is a 35-year-old housewife who complained of fever, chills, and rigors for 2 days, and there were no systemic symptoms whatsoever. And the white cells and neutrophil and CRP are grossly raised, and her urine white cell was less than 5. We screened her with the CT abdomen, which showed features of left pyelonephritis, and the urine culture was negative, but she had been given antibiotics prior to admission by a GP. And her fever responded to antibiotics. So she had pyelonephritis, and usually pyuria is present in people with UTI, but it may occasionally be absent if the infection does not communicate with the collecting system or if the collecting system is obstructed. The fourth case is a 55-year-old British male who had fever for 1 week with generalized fatigue, and there was no recent travel history in the past 1 year. And he was given levofloxacin by GP, but he did not respond in terms of fever. And there was no abdominal pain all along. And the white cell count was 18 with neutrophilia, and CRP was over 300 on attendance to the outpatient. And the liver function test showed only mildly raised ALP, gamma GT. And he was admitted straight away, and ultrasound showed liver abscess. And he had urgent percutaneous drainage, which showed typical anchovy sauce pus. And the amoebic titer was high. On deeper questioning, actually, he had worked in India 3 years ago for half a year. And this is probably when he acquired infection. And his fever responded quite well after 2 days of metronidazole. And just to remind, we have to give a luminal agent after the metronidazole to clear the cyst. And the fifth case is an American student who complained of fever for 1 week with rash and lymph nodes. And there was mild derangement of a liver function test with atypical lymphocytosis. And he belongs to the mononucleosis syndrome with fever, malaise, pharyngitis, lymphadenopathy, hepatosplenomegaly. And the lab typically show lymphocytosis of more than 50% and atypical lymphocytes of more than 10% at abnormal liver function test. And serology confirmed that this man has acute EBV infection. But although they are the majority of cause for this mononucleosis syndrome, but we have to bear in mind the possibility of CMV and HIV, whom I from time to time encounter in a similar syndrome. And for HIV especially, it is an acute HIV seroconversion syndrome. It's important to recognize because patient can be given treatment and that can improve the prognosis of the patient. Other rare causes for mononucleosis syndrome include toxoplasmosis and other viruses, and including and also Mycoplasma, as in our last case, whom also showed atypical lymphocyte in his blood. This is a case of acute HIV with oral ulcers and a rash on the body. The next case is a 45-year-old male with fever and weight loss for 1 month, and chest X-ray was normal, and lymphocyte was 0.3, and CT scan showed diffuse ground glass opacity, and subsequently workup showed that he had pneumocystis carinii pneumonia. Now the new name is pneumocystis jirovecii pneumonia. And his HIV was checked and was positive. And so he has PCP and newly diagnosed HIV. And chest X-ray can be normal in 1/4 of the cases of PCP initially. And it may show bilateral infiltration in 50% of the case. But chest CT is more sensitive, and in terms of showing 70% of people will have showed ground glass opacities or other findings. The next case is a 88-year-old gentleman with fever for 3 months, malaise and weight loss, and seen by different doctors and given courses of antibiotics for his painful scrotum, and which is thought to be epididymitis. And detailed workup after admission shows that he has pericardial effusion on the echocardiogram, and tapping was done, which showed lymphocytosis in the fluid and but the gram stain, AFB smear, TB PCR, and bacterial culture were all negative, but his pericardial fluid ADA came back to be high. And so he was treated as a case of TB pericarditis, and he with a steroid, and he responds very well. And there's a decrease in the pericardial effusion, and there's no more fever, and his generalized well-being improved a lot. And this coming case is really interesting. Is a 59-year-old man who was admitted because of high swinging fever daily for 3 weeks. He had weight loss of around 3 kilograms. He was given multiple courses of IV antibiotics by another doctors during this admission, and his liver function actually was seen to be worsening. And when I was first summoned to review the case, at the juncture of between the day 9 after admission, I stopped all the antibiotics on the first day and reviewed his very extensive investigation of which already performed. And I have checked one blood test which came back to be quite high. It's over 2,500, and it was the ferritin. On repeated examination, and it was found that there was a transient rash over his calf at the peak of the fever on day 12 after admission. And the rash disappeared 3 hours after it appeared. And this is very typical of the adult-onset Still disease. One of the clues is the evanescence. Evanescence meaning it will come and go. A salmon-colored rash, and people may have a high ferritin with leukocytosis, and there's a cardinal phenomenon. And this lady also was diagnosed. Actually, I work with Priscilla, of which she's one of the speakers today, just a few weeks ago on this lady. And she has show some cardinal phenomenon on some of the so-called maybe stretch mark in her rash. And the next patient is a 27-year-old lady with known bipolar disorder, was admitted for fever and rash for 3 days, and which was progressive in nature with swelling of face. She was started on lamotrigine by her psychiatrist 1 month ago. And she has a high eosinophilia count with deranged liver function, and the skin biopsy is compatible with drug reaction with eosinophilia and systemic symptoms. And she was started on steroid and responded quite well. And actually, for this syndrome, there's a long latency between the starting of drug of around 2 to 8 weeks before the rash appears. And there's a list of drugs which might cause a stress. So it's also important to take a good drug history in person with fever of unknown origin. The last case is an Indian patient who visited India and developed fever and chills 2 days after back to Hong Kong. It seems very obvious, right? But he was seen by different doctors and was told, one is told to have flu, and the other doctor told him that he has hepatitis. And so there was no special investigation for him until he was admitted to the hospital when the blood smear showed 20% parasitemia, which was very high. And he ran a very challenging course and admitted to ICU with all the organ support. But luckily, he survived. Many times, patients are visiting friends and relatives in their home country may not consider the trip as a significant travel history. So it's important when we ask the travel history, we ask specifically when you are out of Hong Kong, okay? And then and then we can check the blood smear or the rapid test right away to diagnose the condition. Many times, medical legal cases, either in Hong Kong or overseas, arise because of missing this condition, malaria. So always remember this, if you can remember anything from this talk. Okay, and there are over 200 differential diagnoses for PUO according to literature, and they are often common conditions presenting atypically. A common classification of causes of PUO classify the different entities under infectious, inflammatory or rheumatological, neuroplastic or miscellaneous. And in interest of time, I won't go into details on each one of them, okay? Despite this extensive workup and diagnostic advances, up to half of the PUO cases remain undiagnosed, even in the best centers. There's a tendency for undiagnosed cases in higher income countries, and the proportion caused by infectious diseases is highest among HIV-infected persons, as shown in the chart on the right-hand side, and followed by children, and lowest in person above the age of 65, where other condition may be more common, especially in developed countries. Is there any key to the diagnostic approach with such a diversity of etiological causes? It's important, of course, always, as in clinical medicine, to perform a proper history taking and physical examination to look for diagnostic clues pertaining to individual systems. For respiratory, GI, GU investigations, etc. And investigation should proceed through three tiers approach, and where baseline tests are followed by more specific tests. The aim is to look for potentially diagnostic clues to help to narrow down the diagnosis. However, sometimes this PDC can be distracting as well. And ID physicians are well trained to take detailed history. If there's travel, it's important to know about the details of the trip, including exposure while on trip. For example, someone with freshwater exposure may be more prone to leptospirosis, while someone with sexual exposure may be prone to STIs. For non-ID courses, it was found that joint pain or rash points more to a rheumatological diagnosis, whereas weight loss points more to neuroplastic diseases. And in the physical examination, one should feel for all lymph nodes and look at all the skin surfaces and mucosal surfaces in details, apart from full examination of the different systems. And for tier 1 investigation, one should check the routine ones, including ferritin, LDH, creatine kinase, and the thyroid function, because hypothyroidism sometimes can be associated with fever of unknown origin. And the autoimmune markers, and electrophoresis, HIV and serology, TB, the quantiferon TB gold test or TB skin test, urinalysis, and 3 blood cultures, or 2 to 3 blood cultures, and chest X-ray, ultrasound of the abdomen and pelvis, or CT of the chest and abdomen and pelvis, and echocardiogram. I won't go into the details of the interpretation of each of these tests in interest of time. For tier 2 investigation, the PET scans should be used, and it has diagnostic sensitivity of up to 68%. I think our latest speaker will enlighten us on that. If CT forest abdomen or pelvis has not been done at this stage, it should be done. And also, if the fundoscopy has not been done, it should be done to look for vasculitis, and cryoglobulinemia should be measured. And following imaging and invasive diagnostic tests, some PDC may be present, and some PDC may reveal themselves through the PET or other imaging. And here are some of the definitive diagnostic tests. One of which I just want to highlight is the temporal artery biopsy in some person above the age of 55 who might not have other clues. Even the PET-CT may not be sensitive enough to rule that out in the elderly. And when drug fever is suspected, fever generally subsided within 2 days after discontinuing the suspected medications. After all, apart from the tiered approach to diagnosis, one should recognize major handles to aid the diagnostic categorization for more rapid diagnosis. For example, the presence of rash may point to underlying adult-still disease, SLE or Sweet syndrome, etc. One should actively look for these clues by repeating the history and physical examination as for the adult-still disease cases I've shown you. To conclude, PUO is a common entity, and mostly they are uncommon presentation of common diseases. In the history and physical examination, one should look for PDC, and as for the travel history, one should ask for at least 3 years, as some infectious diseases have long incubation period. And a tier approach, instead of shotgun approach, will be more cost-effective and comprehensive. And syndrome recognition is also important. And one should strive to look for diagnosis other than blindly giving unnecessary antibiotics. And for more details and additional illustrative cases, please refer to these 2 articles on this Hong Kong MA CME Bulletin